I did it wrong.
And Dick, Ephraim is our interpreter today. So that's the other screen that you'll see on.
I need to, there it is. Ah, thanks.
Okay, great, looks good. All right, I'll start making some announcements and hand it over to Julie. So greetings everyone, my name is Rachel Hasna and you are joining our Law and Mental Health Didactic. I work for UNM's Division for Community Behavioral Health within the Department of Psychiatry. Just a couple of things to mention about the CEU process. In the last 5 minutes of the lecture, we will submit a link in the chat. If you use your little mouse and scroll down to the bottom of the screen, you'll see an icon that says chat. You'll want to click on that and that'll bring up your chat box. You'll see the evaluation link there. Click on it, copy and paste it into a browser, complete it, fill it out. And at the end, a certificate of completion is automatically generated for you. It's your responsibility to save it. You can also send yourself a copy. I think you scroll down and look to the bottom right of the screen. If you're joining us by phone, you can just email me and we'll make sure to get you that link. We will be sending out the recording link later. We're not quite sure about whether or when we're sharing the PowerPoint slides, but we will get everybody the link probably around the end of the week. I don't think I'm missing anything else, so go for it, Julie.
Thanks, Rachel. Welcome everyone to the University of New Mexico Law and Mental Health Didactic Series. This series is hosted by the University of New Mexico Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Services Division. We're so glad to have you all here to join us today. My name is Julie Brovko. I'm an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. So first, I want to remind you to join us next week. At that time, Brianne Layden's going to be presenting self-directed violence risk assessment and management. Next, for our talk today, please ask questions in the Q&A anytime you feel comfortable, but just know we're not going to get to them until the end. Also, we always try our best to get to as many of your questions as possible, so we just ask for your forgiveness if we can't get to yours. And for those of you who want CEUs but are on a tight schedule, just know you do have to stay for that full hour, but you don't have to stay longer than that. I'll try to let you know when the hour has passed, but we'll likely be staying on longer to address questions. So now it's time for what we've all been waiting for. I'd like to introduce to you our speaker for the day, Richard Rogers. Dr. Rogers is a Regents Professor of Psychology at the University of North Texas. His research on malingering and related response styles focuses on specialized measures and multiscale inventories and spans more than 3 decades and 60 refereed articles. He edited and contributed to Clinical Assessment of Malingering and Deception, which is now in its 4th edition, and it was nationally recognized by the American Psychiatric Association. Dr. Rogers is also the principal author of the Structured Interview of Reported Symptoms and its 2nd edition. And in 2011, Dr. Rogers became only the 3rd psychologist in APA history to be honored with distinguished professional contributions for both applied research and public policy. Dr. Rogers, on behalf of the University of New Mexico, the Department of Psychiatry and Behavioral Sciences, and New Mexico's Behavioral Health Services Division, I'd like to welcome you and thank you for presenting today. We're so grateful for your time and expertise, and I'm now going to turn it over to you.
Well, thank you so much. That was a very warm welcome. I very much appreciate being a part of this. Julie, you've been doing this since I think 2018, and I think that's just a remarkable contribution. Most of my bio was covered with that wonderful introduction. I'd just like to make just a few brief comments. I started off at Chester Mental Health Center. For those of you staying to the very end, you'll see a picture of me back in the days. That's a maximum security hospital. I then moved to Rush University. Psychiatry and law, and was there in Chicago for about 6.5 years. Took the bold move at that point of going to the University of Toronto. Had a great time there, left in 1991, was Associate Professor of Psychology and Psychiatry. I have been at the University of North Texas. It seems extraordinary, but it's been almost 30 years now, and I'm still enjoying what I do, sometimes more than I did in the earlier days. I think Julie did a great job covering that. So yes, the clinical assessment of malingering and deception. This has been 30 years from 1988 to 2018. Just to ask you to look at the picture on your left, and I'd like to disabuse anyone of the concept that looks at least a bit like me, even with or without hair. Disclosures. Sometimes I put buckets of money because I think people sometimes think that, but I do receive royalties for the SIRS 2 and for clinical assessment of malingering and deception. Particularly if you don't like them, the views expressed in this presentation are those of the speaker and do not necessarily represent the views, policies, and positions of the University of New Mexico. They're frozen in time, as I am there. This is my current research team, minus 2 individuals who are caught up in virtual interviews, because it's that time of the year. I'd like to begin, so this is just an overview, with some general myths about malingering. And I think that will be widely accessible to persons of all backgrounds and professions. And much of this talk, psychologists are famous for jargon. We're going to try to have this be relatively low on the jargon side of things. I'm sure I'm not going to achieve that all the time. And then we'll go into 3 different specific objectives. One is in terms of potential malingering biases, which I think have crept in over the decades into maybe how we're looking at issues of the assessment of malingering and feigned disorder. Second, we'll be dealing with empirical. You notice it's in quotes because I'll leave it to you to decide that data regarding the SIRS and the SIRS 2. And we'll end with information about the accuracy of feigning classification. And that's where things get a bit more technical. But I think with that, I can make some general points and let you look at the information. This way you'll have the information available if ever you need to refer to it. General myths. I think there's probably more than 7, but 7's about enough, I think, for us to address. The first myth is about prevalence, whether it's rare or everywhere. And when I started off early in my career, I ran into individuals who were mid-career who said, but I've never really seen someone who malingers. I think the pendulum was swung, and sometimes what we see is individuals who see malingering way more than what occurs. So 2 national surveys, these are through the American Academy of Forensic Psychologists. Roughly 15 to 18% of individuals met in their minds, these are very seasoned forensic psychologists for the most part, the determination that the classification of malingering. We take that and let's move just a little bit further. We could easily spend an hour on this, but that would be too much for all of us. We have the work of Glenn Larrabee, who essentially says that there is 40% plus or minus 10%. So upwards to half of the individuals being evaluated could be malingering. Young has a kind of a fairly broad perspective in terms of 15% plus or minus 15. And there are a number of other individuals who we could refer to. I think here the takeaway point is what are the criteria? If in fact you use malingering in the sense of the classification that DSM-5 is exhorting us to, then the percentages are probably in the 15% range, maybe 20% range. If you broaden it, if you picture this as concentric circles and you go to broader and broader ones, so not just definite malingering, but probable malingering, and then even further to symptom exaggeration, and then the failure of any symptom validity tests, It is when you broaden, in my mind, diminish the importance of the construct that you can think this 1 and 2 are faking. I think that's important in professional practice because you're expecting every other person you see to be malingering. Then your lens for looking at this is going to be much broader, and it may well bias you in terms of subsequent evaluations. Second myth is that malingering is a trait, a static response style. People are referred to as malingerers. We used to do this, by the way, much of the time when it came to like a person with schizophrenia was called a schizophrenic, and making it a part of the human being. And I don't think this is true. In my mind, it is highly situational and dependent on the circumstances. My favorite case of this was a case I consulted on in Alabama. It's called the capitation case, a reason I bet you could figure out. But the criminal defendant there was clearly malingering, obvious that he was malingering. And one expert opined, well, you see, there's a pattern to his malingering. How did he determine the pattern? He determined the pattern because when he was an adolescent, some 20, 25 years before that, he had malingered at that point. I think it demonstrates the opposite of a pattern. For 20 years, in fact, he had very little trouble with the law. He spent almost no time in mental health. So once a malingerer, always a malingerer. I don't think this carries. Glenn Walters did a classic study. I think it was close to his dissertation days, where he looked at, this was back in federal prisons when they had such things as parole. Folks would, they also had such things as single beds. Those are very hard to get. The number of people who would be willing to malinger to get a single room, not having someone sleeping on top of them, was huge. When people were leaving, no, none of them malinger. Because why would you botch your only chance of getting some sort of freedom? The third myth, that's funny. The third myth is the global style. And this is where people will, in fact, make the assumption, malingering, almost like pornography in the eyes of one of the Supreme Court justices, I may not be able to define it, but I know it when I see it, was kind of a bad quote of that. But the idea that will be obvious. In forensic practice, those who do not use screens and those who don't use standardized assessments, I would ask the question, is this assuming a global style they'll be easy to detect? The work which we've done, a study in 2011, this is based upon the MMPI-2RF, found very few, in other measures, found very few folks malingered or feigned in both mental disorders as well as cognitive problems. The overlap was 9.5%, so 9 out of 10 did not. One thing we have to watch out for on the other side is just because you say something is a scale that measures something very particular, might not be true. And we'll see some data later that, in terms of PTSD, in other conditions, it may not be just because a scale has that in the name, that's in fact what it's measuring. This one, perhaps I went a little overboard with, but there is a sense that sometimes malingering and mental disorders are mutually exclusive. Now, I've never heard any practitioner from any profession say that, but in practice, they might do that. A case I was involved with in South Carolina, indeed, once it was decided by, I think it was the treating psychiatrist, that this person was a malingerer, no other symptoms appeared in the chart, despite the fact this person had very, very severe problems. If we really believe in this, okay, here I'm getting a little silly, but if we really believe it's kind of almost immunity, that if you have one, you can't have the other, then we would have to conclude that genuine persons with genuine mental disorders cannot malinger. And we'd have to perhaps conclude the opposite, that those who malinger can't have genuine disorders. So that here's, if we look at that, and here's the absurd example, the best way to stay healthy then would be to fake back pain, or any pain for that matter. The myth 5 is about common indicators. And this is a pretty pervasive issue, it seems to me. in a place, and we'll touch upon this again with DSM-5. But if you, in fact, decide that you're going to use something common, such as a DSM-5 indice, where it says that if people are in medical, legal, or antisocial backgrounds, those are indicators. Well, those don't hold up very well because they're common. Therefore, within the setting, they do not offer any differentiation. Instead, what we need to look at is distinguishing components, those that distinguish specifically between feigned and genuine disorders. Simply being antisocial, wanting money in a disability case will not cut it because those are common. In terms of the issue of things being mutually exclusive, I did have the drawing from the examinee. I chose to take something from a public art so that we're not doing anything in terms of confidentiality issues. Notice, this is what was marching behind him as he went to murder or, kill his ex-family. He had 300 fire inhaling monsters. I don't know about you. Idea of fire drakes, right? Of them belching out fire is one thing, but inhaling it seems totally incongruous. Adding to the incongruity, each of the 300 had 5 spinning heads with the genitalia changing from male to female as they walked in unison. So you might take a look at this and say, that's preposterous. It is preposterous. He was a terrible malingerer. And in fact, on many tests, the PAI, the MMPI-2, some psychological measures, virtually anything that you gave him, if you looked at this in terms of elevations, they were like the Himalaya mountains. They were huge. That doesn't mean he wasn't severely mentally disordered. Hopefully none of you are having lunch, but what he did, because he was a very delusional man, is because there was a passage in the Bible that was for him personally. He yanked out one eye, was found there, staring at the eye. Maybe the eye was staring back, we just don't know. And then, for any of you who doubt this, years later on death row, he avulsed the second eye. Obviously, I think this carries weight in the fact that you can be an incredibly bad malingerer and be a severely mentally disordered person. 6 is, and this is actually kind of a prelude into the second section. The 6th one is about malingering bias, where we only look for bad news. Sometimes, I think in clinical psychology, in areas of psychiatry, we only look for illness as opposed to strengths. Sometimes I think that's almost built into the traditions of our professions. But if it were to be balanced, we'd also report things that would counterbalance the feigning indices. And the question I ask here, which is obviously a rhetorical one, how many positive findings, that is, those indicating and generally responding, would outweigh or balance out one negative finding? The 7th myth is one of imposed ethic. Imposed ethic means this is the way I see the world, and I'm confident that's the way the rest of the world should see itself. You see this in many areas. I've been involved in a couple of translations, the Spanish Series 2, for example, and these are very, very challenging because of both linguistic and cultural differences. A problem that you see commonly is where we'd like to use a test with a Spanish clinical population with varying degrees of enculturation. And what we do is we use college students being taught in English who are bilingual and make the facile assumption they represent the culture in diverse cultures, within diverse cultures of Spanish speakers. So I touched upon malingering bias, and so let's go for it. DSM-5 defines malingering as the intentional production of false or grossly exaggerated physical or psychological symptoms motivated by an external incentive. In my mind, this description is not biased, but let's go a little bit further. From DSM-3 to DSM-5, the malingering is suspected with 2 or more of these indices. This is what I was getting at before, common indices: medical legal context, marked discrepancy with objective findings, lack of cooperation in assessment and treatment, and antisocial personality disorder. The only investigation that's actually looked at these was myself in my much younger years in a criminal forensic inpatient sample. We had people coding these by criteria. We had 24 that were defined by DSM as malingerers, and we had 113 genuine inpatients. We also had, by the way, some systematic data on these individuals from MMPIs and others where we could draw a clinical conclusion. Looking at DSM, looking at that versus the objective information, we had a true positive rate of 20%. However, that leads us to an error rate of approximately 80%. We're being wrong 4 out of 5 times. Why such a colossal error rate? It is, again, the insistence on those common characteristics. Here is an extreme example volume. I've seen probably a couple hundred malingerers over 3 decades or so. And every one of them had opposable thumbs, opposing to the fingers. If we use this as a criterion, we would be right on 100% of the time. I know that sounds silly and extreme, but look at what percentage of forensic evaluations occur in a forensic context, otherwise called medical legal. That's 100%. What percent of criminal forensic evaluations include people with antisocial backgrounds? It's probably 70% or higher. And what percent are uncooperative? One of the criteria with disability evaluations, by not being completely forthcoming about their strengths and resilience. I bet we're getting up there to about 80%. Let's just take a quick side note. And this is the talk is about people malingering mental disorders or feigning them. But just for a moment, let's look at malignant neurocognitive deficits, the MND model. They used very, very lax inclusion criteria. You've got 2 out of 10 or more. We'll call you a probable. We'll call this probable malingering. But to get you excluded, they have very, very stringent exclusion criteria and must be fully accounted for. Fully accounted in my book is 100%. We're accounting for all the variants, all the percentages. Interestingly, you know, the MND has changed over the decades substantially on 2 occasions, but the research has only been done on the original version. So you have to wonder, if you were to use the MND, which one you should use and under what circumstances. This is just a table from 2011 that shows you some of these. Let me just point to one of the low threshold criteria. If something even suggested that the person might have it, that was considered sufficient for them to be given that as one of the 2 criteria. Is there bias in forensic practice? Here, by the way, what I did is I chose the MMPI-2 because I think most of us have some familiarity with that. If it says very high RINs and TRINs, do you still interpret that as something which is feigned? And I've certainly seen a number of cases where that has happened. For those of you for whom the MMPI-2 is not familiar, this would mean it's an inconsistent profile. And inconsistent profiles confound malingering indicators. What about if some of the feigning indicators were very low, where they're almost never seen by malingerers almost always seen by genuine responders, which actually put that into a report. And what about if they were actually elevated on some defensiveness indicators, the opposite, one might say, of malingering? Would that be included in this comprehensive? Sad to say, but I've seen probably a majority of reports that seem very slanted in one direction. And it's probably the nature of the people who ask me to consult with them, where they're concerned about what those results are like and whether the person is overstating the results in a particular direction. On to SIRS and SIRS-2 classification. There have been, SIRS-2, has come under some considerable criticisms, really for different reasons, but much of it based upon 3 studies. And so I'd like to take a look at those. We refer to these studies by the universities. I do not want this to feel personal in any way whatsoever. So we'll have FDU for the for Fairleigh Dickinson University, PSH for Penn State Hospital, and KSU for Kent State University. Well, let's look at the criticisms. FDU concluded, and I'll read this with you. It may be premature to replace the SIRS without further study or in keeping with ethical practices, the acknowledgement of outstanding limitations of the SIRS-2. What they're saying is, if you're going to be ethical, you'll have to include a paragraph or at least sentences saying, but the test sucks. That's a pretty devastating criticism in my book. PSH, we found significant losses in sensitivity with the SIRS-2 classification rules are implemented in comparison to the original SIRS-2 classification rules. KSU said, the current study highlights the overall weaknesses in the clinical utility of the SIRS. So let's look. As you know, I get royalties on this. It's been my baby for about more than 20 odd years. So I'm trying to present you just with the information and let you make your own decisions. There are 8 particular areas that can be looked at. And I think with this slide, I'm just going to mention those which occurred in these 3 studies. You can overlook ecological validity by asking people to do something that they have no idea how to do. If I asked one of you to fake that you knew how to operate a crane, I suspect the majority of you would not have a clue how to do it. If you don't have manipulation checks, you don't know what people follow. This is basic science, so we'll look at that. I'll talk in a moment about known groups in partial criterion, because that's a bit of a technical area. Criterion contamination. So this is just a quick overview. So when we look at the studies, it'll say, oh, I heard of that before at least. One way of thinking of criterion contamination, because that's what researchers call it, more commonly might be referred to as insider information. So we'll look at that. We'll look at the differences between screens and more comprehensive or definitive measures. We'll look at using criteria that you don't believe in. And standard error of measurement, we'll touch upon that lightly. And finally, the failure to replicate methods. So the FDU study, they used for their partial criterion approach, they used treating psychiatrists from a competency restoration. Tylicki, a more recent person, described this as reflecting subjective indicators with unknown reliability. Is psychiatrist ratings. So it really is, there's no reliability to them. The FDU study insisted on including cases that were uncertain. The original criteria was 7 points. 1 for no indication of malingering, 4 for unclear, some problems appear exaggerated or fabricated, others appear to be genuine, to 7, which was completely malingering. did not provide any of the other criteria for us. That seems like a relatively elegant way of looking at the research. But instead of going with that, they forced a dichotomy. They forced them to choose either genuine or suspect symptoms. Both were reported, but that was the only one that was used in the analyses. So, failure to replicate. I'd like you to think of this. If I have a recipe, maybe it's about baking a cake, and you don't follow the recipe, and you tell me that the recipe is wrong, my question to you, someone's wrong. Is it the person who made the recipe? We don't know. Maybe it is a bad recipe. But if you don't follow the recipe, you can't say it's wrong. So the SIRS-2 classification has 4 groups: genuine, indeterminate general, indeterminate evaluate, and feigning. FDU decided we're not going to follow the recipe. We're going to do whatever the heck we want. So they, under genuine, they collapsed. Genuine, indeterminate genuine, and indeterminate evaluate. For feigning, they had a second option where they included indeterminate evaluate with that. This is pretty basic. Gotta follow the recipe. Another problem for the FDU is simulation designs. I'll give you a couple of references here to show this has been around for a long time. The person must have knowledge and familiarity with what it is that they're trying to fake. In that study, they took relatively mentally well persons. I think very few had had any mental health histories. Fewer had even any criminal histories. They asked them not to fake a mental disorder per se, but also to fake a legal standard. They were supposed to simulate incompetency to stand trial, when probably most of them may not have seen the inside of a criminal court, and definitely not during a case of competency to stand trial. Told about symptoms, but not told about anything else. So the real question here, pretty basic: how can you fake what you do not know? Criterion contamination. This is a fundamental problem in science, a fundamental problem that has to be addressed. If you don't keep things separate, then you're likely to have a contaminated and otherwise confounded results. Well, inpatient settings are the place where there's always formal and informal communications. Sometimes these might be directly between psychiatrists and psychologists. Sometimes they are mediated through treatment notes. Other times, in fact, it is other staff that communicate what another doctor has said. Particularly when you're preparing an inpatient forensic report, you could see how collecting these types of information would be considered expected under those circumstances. The authors of this, by the way, readily admit there was criterion contamination. They said, where the initial impressions in pre-discharge reports conflicted or omitted because these cases may have been confounded by the results of psychological tests, and the SIRS in particular. So I appreciate them going that far. I think the problem may be 5 or 10 times worse than what they describe. PSH was most of these in keeping the details to a minimum. I haven't mentioned the sample size. Here it's pretty significant because we go from 263 down to, I think, less than 70. So less, in fact, is addressed. They had 39 who were presumed feigning patients out of that. We'll talk about that in just a moment. Failure to replicate. 4 groups. They for some reason that truly escapes me, they decided just to collapse 3 indeterminate groups into 1. For the criterion groups, they really failed in terms of the criterion groups. For the ones who were presumed patients, this was based almost all, 85%, on the MFAS, or the Miller Forensic Assessment of Symptoms test. So that was basically. More than that, though, they failed to establish a genuine group. The current was deemed inadequate or deriving a presumed genuine responding group. Despite acknowledging the fact they couldn't do it, they proceeded with the article. They used for the non-feigning group, they used a series of rules not based on any empirical literature to chop that group down so that it was 92% of them were kicked out and only 22 remained. We have no idea what the results would have been like if they had taken such a extreme action. Here's a fundamental flaw. Initial screens just can't be used to validate measures of classification or more comprehensive measures. My example of this is, let's say we want to study prostate cancer. So we flip things around. We treat the gold test, the gold standard prostate biopsies as the screen, and we make the PSAs or the prostate-specific antigens the way to test whether the biopsies work. We really took the world and turned it upside down. It doesn't make any sense to do. It doesn't make any sense, and it doesn't make any common sense, but it doesn't make any statistical sense either. Screens want to keep as many people in as possible. Trying to keep those people in, what they do is they, in fact, allow the false positive rate to go up so that they have very few false negatives. False positives and false, without going into the details of this, it's like a seesaw. So if one goes up, the other goes down. That's really what they do. Measures, more definitive measures of a classification, minimize false positives, because we really don't want to call someone something that they're not, or to designate something which it is not. Let me make this clearer. Miller, the author of the MPAS, spoke forcefully on this one. She said, in fact, a screening that minimizes false and negative classifications is more desirable than a measure that minimizes false positive classifications. For this reason, the MPAS cutoff score has been chosen to minimize false negatives rather than false positives. If the folks from PSU had read the manual, I would hope that they would not have engaged in this in the type of analysis which they did. KSU, the third and final of our trio. Mostly disability cases with a small percentage of criminal defendants thrown in. For them, they used the criterion groups were based upon feigning, primarily based on the two MMPI-RF validity scales FR and FPR. Guess what? Another failure to replicate. They took, instead of having the four groups, they took the two indeterminate groups and squished them together. I have done a number of studies on different variations of the MMPI-2 and MMPI-2-RF. I think I might even have a study or two on the original MMPI. I like to measure a whole bunch. The fact is, though, you have to take into account the standard error of measure. This means what is the likelihood that you'll get something right? You put your bullseye. How often will you hit inside the bullseye, the second or third or fourth concentric ring outside? It's absolutely critical foundation in science. You've got to know what that is. Well, with a T-score of 10, that's a standard score of 10. At 50, one SEM brings us from 40 or 16th percentile to the 84th percentile. Now, I realize some of you research is not the thing that excites you. But if you think about this in terms of getting into graduate school for your particular profession, if you were in the 16th percentile of those applying, I don't think you get in. If you're 84th percentile, depending on the competitive of the program, there's a very high likelihood of all other things are going well that you're going to get in. So whenever we have a 68% fluctuation, notice I'm not picking on the 95% confidence interval. It simply doesn't make sense. The service, by the way, based upon inter-array reliability, is a very high. Is very reliable, and so has a very, very low SEM, averaging for the primary scales of about half of a point. Simple conclusion is you can't use the KSU indicators, which are highly imprecise, to measure something which is precise. It's kind of an analogy back to the screen in comprehensive mind. One of the things they did do is they removed some of the inconsistent items, but they left in a range of items that could reflect, as Ben Parath points out in his 2012 book, carelessness, non-cooperative test taking, which doesn't mean necessarily faking. Person just might not be into the test that was given to. It also has a large measurement error, meaning that some of those tested out at 78, 79, probably their true scores would have been above 80. Some of the text inaccuracies trouble me. The modified total index is inaccurately described. The fact that genuine respondents can't be in the probable range, no, that's wrong. And figures 1 and figures 2 also have inaccuracies too. Here is the final issue. I bet some of you are hoping we get to the final issue sooner than later. The fact is the original SIRS had more than 2 classifications. 2 of them were made overt, feigning and genuine. But those with 1 or 2 scores in the probable range were considered heightened risk. If you had 2 in the probable range, it's an 8% chance that you can be feigning. It also had some where there was just not enough in the genuine range was to say definitely this person is being genuine. So you really do have conceptually the idea that it's more complex. So if we were to try mapping on the models, it would look differently than what was reported in these research articles. I just thought to kind of travel down memory lane. This was an initial draft from 1986 of it, and it's been a long journey. Accuracy of classifications. Let's take a look at this. Okay, I know sometimes, even with, or I should say with some students in psychology, their eyes begin to glaze over whenever we talk about statistics. I promise you I'll keep this as clean as I can. What about if I gave you a medical thermometer and I said the SEM, what that really means, Janet, is if 2/3 of the time it's going to be within 5 degrees. So we could have someone at 100 that actually could have a normal temperature. We have someone who is incredibly feverish. I would submit that that medical thermometer is useless and potentially harmful. I've argued really for a number of years now that for forensic assessments and for clinical assessments, we can't keep ignoring the fact. In cognitive intelligence testing, we don't ignore this. We shouldn't be ignoring it when it comes to forensic cases. Here's a tiny little prod with my forensic paradox. Should forensic practitioners be not forthcoming about uncertainties in their classification, about examinees who are not forthcoming in their presentations? I think we should be forthright about what we have and what we don't have. I think an important case, and I am not an attorney. If you'll notice on most of my forensic books, except for the one in 1986, I've always had a legal scholar with me to kind of hold my hand and make sure I don't get lost. But we're talking about these standard errors of measurement. This is a death penalty case. the conclusions appear like they might be more generalizable than just simply dealing with death penalty. They stated the SEM, standard error measurement, reflects the reality that an individual's intellectual functioning cannot be reduced to a single numerical score. There were two takeaway messages on this. They said that it must be taken into account, acknowledging that the error is inherent, using a score without the necessary adjustment. They also stated that a 95% confidence interval was legally required. And they demonstrated their understanding of this relative to a quote from the APA, which was the primary author of a brief in this case. That brief, since we have a diverse professional audience, you can see covers the American Psychological Association, American Psychiatric Association, the American Academy of Psychiatry and the Law, and same with national organizations and the National Association of Social Workers. The SEM, in turn, allows for the calculation of a range of scores. Typically, so this is from the brief that we just saw the signatories on, typically plus or minus 5 IQ points. And I apologize, there's a lot of text there, but I did underline what I thought was interesting, something perhaps more open for debate, is if you report it without it, there's a misleading sense of precision and is not in line with the standards of practice. They also talk about to interpret a test properly. It seems to me, and I have a legal scholar who has a much narrower interpretation, that the way this is said did not mean that it was entirely intended for only death penalty cases and only IQ. It seems to be said in much broader strokes. We look at imprecision, and this is why I'm going to go a little bit on the quicker side. Where on the MPI-2 test manual, I was unable to find any data relative to this, but we did have a large sample of MPI-2s who were able to calculate the SEMs. Pretty bold red, isn't it? Here, if you look at the raw scores, these are raw scores, so these are pretty substantial. And so I just make them available to you because I imagine that many of you are continuing to use the MPI-2, that you'll see it's pretty substantial. The FP, which is the infrequency psychiatric scale, seems to really stand out as being excellent among us. MPI-2RF, I think it's wonderful that they included in it the combined clinical alphas on over 3,000 protocols. See what that means, and we've already touched upon this, so I'll go very quickly with it. What it really means is that for most, there is a 10-point spread for the SEM, which would be a 20-point spread in terms of a 95% confidence interval. Having a 40-point range is a very, very large range. I would submit in practice that means that those findings should be confirmed by other measures because of the potential inaccuracy of them. I do not have a copy of the MPI-3. Someone very kindly sent me a copy of this table. In it, the median alphas are limited to outpatients only, and that could actually account for substantially for some of the differences that we see, because in general, these are lower than we saw for the MPI-2 RF. FP, unfortunately, remained perhaps stubbornly at 10, which is a very wide variation. I wanted to just make a quick point here, because I touched upon this a little bit before. Just because of scale, so this is the infrequent somatic for people feigning somatic issues. A meta-analysis in 2017, in fact, has looked at this and frankly, it's not sensitive. So 0.56 or 56% of those who are somatic feigneds scored, but the scores are higher for alternative explanations, such as feigned mental disorders and cognitive impairment. Maury's manual on the PAI reports only on normative, we would say non-clinical samples. Only one I found was Wound in 1998, reporting and showing a NIM of 10 T points. So in other words, a pretty large variability. We look at the accuracy of these. Let's look at 70T, you'll see that the accuracy is probably varying between 20 and 30 points. Relative on the NIM, it's about 20 points. You need to take this into account, and attorneys here in the audience need to ask people, what is the SEM? Even if you don't know what it is, it's important, if it's a case of feigning or malingering, ask, what is the SEM? And here are two pictures of me as we are finishing up. This is a picture of me on the Mississippi River. I was a newly minted Ph.D. at the time. We'll see, had a bit more hair than today. And then after I've been at Rush for a bit of time, there's a picture of me there. And I believe that all we have left is the references at the end. Thank you so much.
Thank you so much. We have a number of questions. Let's see here. The first one is, the individual says, I've always been bothered that the sample used for the SIRS included what appeared to be oversampling of dissociative disorders. Can you help understand this? Help me understand this, please.
Difficult because I'm not sure in terms of the question. There was a study done by Brand, actually a study and then a follow-up study that looked at folks with dissociative disorders. With the SIRS and the SIRS-2, one of the things we've avoided, because I would consider it to be a kind of a fatal trap, is saying, can you test this out for a particular disorder or diagnosis? And what about if you have dissociative disorders with something else? The take which we have is that most of the persons in our samples have multiple diagnoses. So we're not trying to make it diagnostic specific. I hope that was helpful.
The next question is, do you know the base rates of people who are both malingering and have a serious mental disorder?
Actually, that is a wonderful question. Unfortunately, I don't have a wonderful answer. I would say it depends on the setting, but in the settings I've worked in, which are primarily criminal, almost always that's the case. So I would say safely, probably the majority of them is it both ways. And would it be great if it weren't? That's what's so appealing about that, the idea of either or assumption, is it would make our lives as forensic professionals just so much easier.
Next is, do you have an idea of the prevalence of malingering in those with intellectual disability? And can you discuss valid assessment instruments in the ID population?
So by that assessment measure, I assume they're referring to the SIRS? Okay.
I don't know.
Well, and actually, I'm really impressed by the qualitative questions. We've had hundreds of studies, in terms of people faking memory deficits, other kind of cognitive issues. But in terms of intellectual disabilities, the studies have been quite small and not particularly well done. So let's assume, so that was my attempt or my stab at the first question. The second part of that is with the SIRS, if the person has a mild intellectual disability, then it depends on the person's capacity. And if the person is able to, and let me say this in the very beginning, you never start someone off with the SIRS-2 as the first measure. I mean, we always think broadly and then think, so one would always have some information. How well does this person attend and comprehend? The reason why in other words, it's a case by case basis with folks with mild intellectual disability is because that is a composite score. You know, the persons have fairly good VCIs, which is in terms of verbal comprehension index. If they have that, then there's a reasonably good chance that they can. But the notion is, when always, first of all, you've done other testing beforehand. The one thing we want to avoid is garbage in, garbage out, which is a computer phrase. And I've had people call me up, or email me, fortunately not in the last decade, and saying, well, I gave this test to someone, and they really had very limited intellectual ability. Can I just pretend I didn't give it? And they didn't think it out. You know, use care. Do not give it to someone and then try to explain it away, because that makes no sense at all.
This next individual would like to know if you have any opinions regarding the SIMS. Their impression when they did use it was that it overdiagnosed malingering in people who were in fact psychotic or had severe traumatic brain injuries.
Yeah, yes. So the SIMS is an interesting measure. And actually, Smith was the person who developed some of this as part of his graduate training and was in contact with me during that time. So, you know, I want to acknowledge that relationship there. The SIMS does not have well-defined detection strategies. If you'll notice that I think you have to have detection strategies as a way to have this be empirically validated. They really do not have those well. So I think they're right that it can overclassify individuals. I do have an article that probably through you folks, I can get you the site on that, where we looked at this, I believe it was the SIMS in terms of some improved ways of examining this.
That would be great. Thank you.
Might I add that, you know, much of the studies that have been done with the SIMS have been done with feigned mental disorders. Although it has those scales for cognitive, there are issues with them. And one more thing, there is a meta-analysis out in 2014. But it collapses groups so that they'll include in some groups, instead of having a clinical comparison sample, they'll have undergraduates. We all know that if you take undergraduates and you ask them to fake schizophrenia or something else, and then you take some others and say, answer normally, we miss the boat. The boat is, can it compare genuine schizophrenics, persons with genuine schizophrenia to persons with feigned schizophrenia?
Thank you. The next question, the individual says, while there are analog studies where trained participants try to malinger without being detected, do you know of any studies where individuals are given feedback after their first attempt and are reassessed? How well can such individuals perform their performance upon reevaluation? The real life example is a defendant who's identified as malingering after bombing several feigning measures, listens to testimony about how he was identified as malingering, later is reevaluated for malingering, and provides an attenuated malingering profile upon reevaluation.
That's, by the way, although it's a question, it's a great comment also. And this is a problem. It is a problem, and occasionally it's not through testimony as much as perhaps legal counsel or persons who work for legal counsel, that they're educated about how they failed to the test. There was at least one case, you know, I do these kind of curbside consults where someone, 15, 20 minutes, we just chat about things. And certainly they ran into a case like that. One of the things that the Service 2 has built in is it's called the subtle symptoms index. So if the person does too much of that, they will pop up as someone who is whitewashing everything. But that could be used certainly more extensive validation. But that's at least one attempt when we get someone who goes from looking very, very bad to too good to be true. You wonder a little bit about whether that's something which the person should have retested the person after, in fact, is the finding of malingering and the divulging of the strategies or of the skills involved.
Thank you. This next person is asking about how to word or qualify reports regarding measurement error.
Yeah, I think, and see, that's where this gets to be so important. I think that when you make a statement, that you could make a statement, and this is where, let me use the PAI as an example. I think when you get, with the PAI, we know when the NIM scale is at 110 or above. That's really high. But we know at that level, there's a high probability that this person is feigning. With that much away from even elevated scores, I think you could feel comfortable saying something to the effect, this person had such an extreme score, that would be one way of addressing it. But I don't want to circumvent the question. I think the question could be answered that this person has a NIM score of 80 or 75, but we could say that is kind of falls in more of an indeterminate range. It's a possible indicator, but we also don't have firm evidence. So what I'm really trying to do is avoid using the word like SEM in most reports, simply because there could be a rabbit hole.
Okay. Is the SIRS not useful anymore, and must we only use the SIRS 2?
Hey, Julie, let me interrupt real quick because it sounds like folks are having issues with the CEU link, and I'm not really sure what the problem is, but if you guys just copy and paste it and save it somewhere, try it a little bit later, everything will work out. So don't panic. And if you're not getting your certificate, you can always email me.
Thanks, Rachel.
Yes. So actually, I have a good answer for it. If you score the SIRS 2, you will also have the scores for the SIRS. So that if you really want to compare, I was involved in the case where they said, well, we've heard the SIRS is better, so we want to make sure you give the original SIRS. Well, the good news is the items are exactly the same. The scoring and the interpretation and decision model is different. So you can easily look across both of those and see what the answers are. It seems to me, though, that to use the SIRS without these changes. I did try to see, by the way, if we could put out something for those who had SIRS, SIRS protocols. The publisher, PARA, is actually an excellent publisher. I've dealt with them for, I think, 30 years, since 1984. So I've dealt with other publishers. I won't say anything about them, but I would say I think that PARA is very good at this stuff. They said that would be financially infeasible to do that. And by now, there shouldn't be any original SIRS, or one would kind of hope at this time. SIRS 2 came out in, 2010? You'd kind of hope a decade later you wouldn't have those. But I think the clinical comparison of the two can actually be quite helpful. So if you have any doubts about the merits of one scoring versus the other, I think in most cases, the results are going to be very close.
Given COVID, what are your thoughts on administering the SIRS 2 via video conference?
I've been asked this question a number of times during our COVID-19 time. I'm ambivalent. I think that if you have established good rapport, and this is a part of, so this is not something rushed onto the person, if you establish really good rapport, that in fact that's something that likely could be done. We have not done the research in terms of remote versus in person, but that's my concern. Let me tell you very, very briefly about a failure of mine. And that was, I was invited, it was actually the Center for Forensic Psychiatry in Ann Arbor, and they wanted me to interview a defendant using the SIRS, wanted me to interview him and then use the SIRS too. Well, the guy arrived, you know what jails are like. He arrived, I think, 2.5 hours late. I had 20 minutes. The guy didn't know me. I said, "Hi, I'm Dr. Rogers," and started off with the first question. He didn't know me. He thought I was strange. Let's face it, if you start with the first questions of the SIRS, you do sound strange. And so this is really my strong hesitation. I would think that would be something that people would do, and I would hope they would do it only in cases where they felt they had excellent rapport.
When you think about goals for the future development of better malingering tests, what do you think are the most important areas to focus on besides incorporation of SEMs?
Right. I think one thing that's really important is that when we put out measures, and because now to say to our professionals, to the courts, this is malingered, but then not be able to be more specific and then to assume that if you're faking one thing, you're faking everything. That gets hard. So one of the things we're working on is ways that so one of my students, and this is in the area of ADHD, but came up with a scale for the MMPI-2-RF for simulated ADHD. We get tons of referrals in psychology centers located in universities. And so it's a way of sorting that out. And what we did is, as opposed to saying, oh, these are ADHD type items, they must work, we tested it against protocols of people with genuine ADHD, people faking ADHD, people faking general disorders, and I think there's another sample. And so we were able to that way say, because that's one of my concerns, I did have a slide about this that really just only touched upon it. The scales for faking PTSD, most of those like on the MMPI-2 really don't work. They work for that, but they don't distinguish that from any other type of faking. In which case, then we're misleading individuals about what it is that's actually going on with them.
Do you have any recommendations regarding evaluation methods for feigning in juveniles?
It's amazing to me how few studies have been done in terms of faking. I looked at this back before COVID-19, about a year before that. I had a student who wanted to look at the malingering literature with juveniles and attempt to study in this area. I was appalled at what's available. So I'm not really terribly helpful. We've considered a study relative to the SIRS-2. But I think, so we're going in a couple different directions. The most fruitful one, I think, is the use of it with individuals with lower cognitive abilities. And I'm hoping that we can get this off the ground by, the language is fairly simple, but to even simplify it further. A juvenile center close to us, a psychologist there raised this as a possibility. That was before the pandemic. Getting something like that off the ground, doing research with juveniles with criminal cases and getting that through an IRB is something of a heroic effort. But back to the question, we have very, very little that we can use. And one person who's had someone they wanted to test at the age of 17, I didn't know what to say. There was part of me that felt like saying, because I just get slapped, saying, wait a year. Because at least, you have that. And I think some people have used, for example, with older adolescents. But we know adolescence covers a broad developmental period. If you put a huge caveat in, if you gave the PAI to someone at the age of 17, and I'll measure maybe up to social maturity, I would think other people might look at that as you did due diligence, especially if you said in your report, this appears to me to be the best that we can do.
This person says, I believe you touched on comorbidity and exclusivity. Because malingering is not a factitious disorder and Munchausen syndrome is a factitious disorder, is there nevertheless ever any nexus?
That's a question we don't know a whole bunch about, but I have a little bit of good news. And that is, I have a student, we just submitted the article, who did a simulation study looking at the differences between a factitious presentation and a malignant presentation. So I'm excited about the research. Let me quickly add, as the first in its area, it has a lot of methodological issues. But we were able to find and establish some differences in terms of particularly the relationship between the factitious presentation and the person's interest in treatment providers. I think if it has any relevance, it would be in the civil forensic area. Factitious is oftentimes involved, despite what DSM-5 said, a over-investment in the role of being a sick person and having in that investment in that role. I'm not sure what forensic hospitals are in New Mexico or around the country. I think rudimentary mental health care, you're fortunate if you get that. The opportunity to develop an overly invested relationship within the forensic realm seems pretty remote. But we did come up with a preliminary indicator that obviously needs cross-validation, because I think this is something overlooked. Could I add just a quick thing about the DSM-5? I don't know what they were drinking or smoking. I don't know what they were, because you know the rules from DSM-3 to DSM-4 are, there's been considerable modifications. But when they said the motivation, the feigning is seen even in the absence of an external incentive. Who talks that way, first of all, right? I mean, because how do you know? The only way that you know is sometimes you wait. So we're not going to diagnose you yet. We're just going to wait for another couple of years. And if you think that's silly when I say wait for a couple of years, there were a couple studies. Now, these were of factitious odds by proxy. But I think in one of them was 15 months and the other one like 21 months between the time the factitious presentation started, because that's only an estimate, and indeed the time in which it was evaluated. It makes no sense in forensic assessments to say, come back in 2 years and we'll see if things have changed.
Why would we not tell a person at the beginning of the evaluation that we'll be assessing whether or not the person is genuinely responding?
I think we can. I think if you said, I'm going to give you this test and watch out for these items and those items. So, right, if we almost coach them, that seems to me highly problematic. But one of the things I might say, and there's no magical words, I might say, when I do forensic evaluations, one of the things we're interested in is whether this is a true picture of you. And so one of the things we do is we have these built-in indicators that we can look to see if the person really describing things in the most accurate way which they could.
Why does the SIRS-2 contain a number of items that are not scored?
Well, just because I want people to take more time doing their evaluations. There was a person who actually who got after me because he wanted to get rid of all those items, etc. What it comes down to is something we could experiment with, but that is that if you change the order of the items, for example, we know that it can actually change the protocols. So you saw on that thing back when I was at the University of Toronto in Medfords, where it said Form A. So a Form A and a Form B. We found if you change from A to B or B to A, that the changing, which is of course changing the order in some ways, actually the scores changed a bit. Since it only takes, on average, 30 to 40 minutes to administer. We do know that averages lie. In fact, is someone who is really kind of with it, probably not particularly mentally disordered, sometimes 20, 25 minutes works. And there are other folks where everything goes much slower. But yeah, so that it's really from a standardization perspective.
All right, our final question for today. What are your thoughts on the term negative impression management as opposed to malingering? Does it become more useful not to use the weight term of malingering to describe observations and data?
I take a somewhat different perspective on this. And the perspective is that if we have precise words, then we know what those words mean. But there's a lot of words out there which can mean almost anything. I do not like the word underreporting because of its vagueness. So this person is, I think, maybe projecting, is very, very well-minded and is trying to be a proper professional. But sometimes what happens is those vague words are interpreted as a saying, you're faking bad, whatever we call it. And so the broader term could actually, I've just put this out there for those listening, could actually maybe boomerang. Because if I think that when you say fake bad, you're just being nice and you really mean malingering, the fake bad group may be 2 or 3 times the size of the malingering group.
Well, thank you so much. We got a lot of really positive feedback. A number of people asked if you'll do a part 2. So you'll be hearing from me again soon. But we really appreciate your time. This was fantastic. And thank you so much again.
Oh, you bet. I've really enjoyed this.
Good, we're glad. Everybody, there's still a number of you on. It looks like the link's working. Just remember, save it, save the link, and also make sure you print a copy of your certificate or save a copy of your certificate. Rachel, did you want to add to that?
Oh, just, yeah, same thing. It'll work. I mean, I don't know what's going on with the website, but the link is fine. So it'll work. Just save it and don't panic. And you can always email me and I'm happy to help. Thanks so much.
Thanks,
right,
everyone. Thanks, Dr. Rogers.
Thanks, Ephraim, for your services.
You bet.
Bye.
Bye-bye.
Okay, bye, everybody.